Dr. Sibasis, Dr. Kapil, Dr. Saurin, Dr. Garmin Balodia, Dr. Dinesh Bhai, Dr. Devendra, Dr. Spandan, Dr. Pradeep Bansal. Kindly introduce the speaker and the subject, please.
Good morning, everyone. Now, interesting topic of Blackman intervention. So we have now commonly seeing the osteal LAD or osteal LCX lesion, and crossover stenting is now we are doing routinely, and it is showing a favorable outcome. So we have one interesting case, 68-year male, post-PTCA, left main to LAD crossover stenting 2 year back. Now check angio suggestive of pattern stent to LAD with 80% de novo osteal LCX lesion with large high OM and RI branch arising from the across the previous stent, arising from the LCX, and previous stent size was 4.5, 38 mm. So we have learning objective of management of osteal lesion in stented or non-stented segment, drug eluting balloon as the alternative management for instant restenosis, and use of imaging in instant restenosis. So first of all, I would like to invite Dr. Chirag Seth. He will talk on paclitaxel drug-coated balloon assisted by imaging is preferred strategy for LCX osteal revascularization in current scenario.
Good morning, everyone. Thank you, Dr. Kamal sir, for inviting me for this talk, and congratulations on organizing this event year on year at a gigantic platform. So the anatomical complexity of a given case lies in its description, and there is no doubt that this is amongst the most complex case that one can encounter. For any intervention strategy, the key questions that we ask is whether the patient is diabetic or not, whether the clinical presentation is symptomatic or not, whether this finding is done as a just part of check angio or patient is really symptomatic of angina. That is what is important, because always a trial of optimum medical therapy remains if patient is minimally symptomatic or asymptomatic. Of course, the anatomy is important. Like typically it's the complex left main bifurcation disease 001. Extent of osteal disease, we should know whether it is focal or diffuse, and whether the circulation is left dominant or a right dominant. Syntax score assessment can help us in finding out what is the right strategy, apart from LV ejection fraction, severity of MR, and whether index PCI was image guided or not, whether the final kissing balloon dilatation was done or not, and what is the size of blood circumflex artery. Why it is important to answer all these questions is, was the findings, good size circumflex, dominant one, diffuse disease, diabetic, LV dysfunction, naturally our decision could tilt more towards bypass surgery, even though it's a non-LAD lesion, looking into complexity of the bifurcation PCI. And less of the complexity, maybe one can still think in terms of offering intervention as an alternative to bypass surgery. In the back of the mind, when we consider non-LAD substrate for bypass, there is always a question how the venous graft to that circulation is going to behave in long term. And therefore, I think this debate has come up whether we can offer drug-eluting balloon or stent to this kind of anatomy. So I think this kind of picture closely relates to what has been given to our patient profile, that you have patent LAD and left main, and you have osteal circumflex lesion, and you have a large ramus coming off from this lesion. So whether to treat this lesion with the help of PCI or PCI with stent or drug-coated balloon. So let me clarify here that this description does not qualify for instant restenosis. There is likelihood of a plaque shift from previous bifurcation PCI, and there could have been native progression of the disease at the circumflex origin. There could have been endothelial injury of the side branch ostium by kissing balloon dilatation of a previously done provisional strategy intervention. So this is likely to be a de novo osteal LCX 80% stenosis rather than instant restenosis. I hope chair and monitors would agree to it, and we take it forward. So for drug-coated balloon PCI in de novo lesion, there are a variety of data available, and most of them have come from observational registries and small case studies. And the DCB group had shown variably lower rate of 2-year MACE rates in multivessel disease. Some of them had shown that the LAD shows lower rate of target lesion failure compared to DES in de novo lesions. Some of the other studies had shown that diffuse disease and CTO lesions, 3-year event rate with drug-coated balloons have been better compared to DES arms. Moreover, they have also shown that the angiographic late lumen loss is much less comparatively with the drug-coated balloon when the paclitaxel has been used when compared to the drug-eluting stent-only PCI. So all these have been relatively smaller studies there. We don't have a large randomized control trial data to really bank upon our decision. Issues with the drug-coated balloon are which drug, sirolimus versus paclitaxel. Paclitaxel is supposed to be better because it has got lipophilic characteristic, and therefore the tissue delivery is better. Availability of local concentration is better in the event of delivering the drug with a drug-coated balloon. Loss of drug during transit is always a concern, and considering this kind of anatomy require prolonged inflation time for a left main PCI. So that is always a concern whether we should consider balloon in this kind of anatomy. And lastly, the bailout stenting in DCB treated segments. Let us say you go ahead with the plain balloon angioplasty, drug-coated balloon angioplasty, and there is a dissection, then you need bailout stenting as an option. Variably, the incidence has been between 3 and 30%, and most often what happens is if you have a NHLBI classification system, intimal TAS higher than type C, then definitely bailout stenting is required. There is reduced flow less than TME3, again stenting is required, and when the residual diameter is higher than 30% after balloon dilatation, stenting is required. So we have to keep that arm open. It's not so that dogmatically we say that I will continue to treat with DCB only. In the event of these adverse events, option of bailout stent always has to be there. If we see the data from DCB versus DES, a recently published REC cage-free 1 trial has shown that in non-complex de novo lesions, the DCB arm could not achieve the level of non-inferiority, and therefore they discouraged use of DCB in non-complex de novo lesions, and drug-eluting stents are preferred. But if you look at recent data published by the Korean group, wherein complex bifurcation and complex PCI patients drug-coated balloon angioplasty, and they compared with the large propensity matched cohort of patients undergoing drug-eluting stent angioplasty, large majority of those patients, when they compared, it shows that 26% patients had left circumflex lesion, 20% had bifurcation lesion, 12% were ostial lesions. So they were typically complex patients, and in all those complex patients, when they saw the outcomes were equivalent. And these outcomes between DCB and DES arm at the end of 2 years, when they're equivalent, they concluded that DCB could have role in multivessel disease, bifurcation, complex anatomy, and CTO PCI. Apart from that, one of the important observations which was confirmed in this registry is also that despite lower final minimal lumen diameter in the DCB arm, event rates are comparable in drug-eluting stent arm. So we should not be getting concerned about lower acute luminal gain whenever we treat with drug-coated balloon therapy, more so with paclitaxel, because almost always there is late luminal gain, more so with paclitaxel, less so with sirolimus. What about hybrid strategy? Like in this case, what we are proposing is a hybrid strategy. Patient has already had a drug-eluting stent in left main LAD, and now he has a de novo lesion in circumflex ostium. Do we have any data? Yes. The Italian group has published data from this year. They have published data in the HYPER study, 106 patients with diffuse disease or bifurcation disease, and out of which 50 patients who had a bifurcation disease, they have been analyzed. And those study had true bifurcation lesion, 111, 101, 011. Main vessel reference diameter more than 2.75, side branch between 2 and 275. So main vessel got drug-eluting stent, whereas side branch electively got paclitaxel eluting drug-coated balloon. And what is important was pre-dilatation was mandatory before drug-coated balloon dilatation, and balloon to vessel ratio was 0.8 to 1, and it was either a semi-compliant or non-compliant balloon dilatation according to local practice. And here again, more of the patients were LAD diagonal. There is no patient with a left main bifurcation because of the size restriction of the side branch. So No patients had been included of a left-mean bifurcation in this group, and what they found was that majority of patients where this strategy was used, the kissing balloon inflation was incorporating drug-coated balloon in the side branch arm. And if we see the QCA data peri-procedural, they found that despite a lower acute luminal gain compared to the drug-eluting stent in the drug-coated balloon arm, if you see the one-year outcome data, procedural success more than 96% and ischemia-driven target lesion revascularization in DCB arm, drug-coated balloon arm, was 0. So excellent one-year outcome as far as treating side branch with a paclitaxel-coated, drug-coated balloon is concerned. The discussion between DCB with paclitaxel versus sirolimus, yes, there are data which says that despite equivalent clinical outcomes, drug-coated balloon paclitaxel is associated with better luminal gain on a longer-term follow-up, and that therefore, when you analyze the data at a year or two, the outcomes may be equivalent, but a net luminal gain, it would definitely translate into better clinical outcome in longer-term follow-up. That is what my impression is, and probably we'll need to have longer-term data to really find the difference between the two arms. A recently published meta-analysis between of randomized controlled trials, it has shown that despite clinical outcomes being equivalent, net luminal gain definitely is better with a paclitaxel-coated balloon as compared to the sirolimus-coated balloon. So when you have this kind of issues with paclitaxel versus sirolimus, because there is likelihood of loss of drug during the transit, and that is likely to be very crucial when we are using sirolimus eluting drug. And again, prolonged balloon inflation time is also crucial, and therefore we need to understand about a newly introduced balloon to us, that is Protige. Protige is a paclitaxel-coated balloon by Translumina, and the balloon is manufactured in such a way that it is inflated and then folded, and during the among those folds the drug is applied. So there is least amount of drug loss when you introduce the balloon to the target site, and only when you inflate the balloon the drug is delivered. And because of less loss of drug during transit or minimal loss of drug during transit, almost maximum tissue delivery is possible at the site of application of drug, and therefore your inflation time is also likely to be small. Rather than 60 seconds, it is 30 seconds alone. And again, you can have multiple inflations to deliver the drug locally if required clinically. So with this Protige balloon, which is paclitaxel eluting, there is a Pearl registry data which has been published in almost more than 500 patients, out of which 131 were de novo and 380 with instant restenosis. And in all these patients also, if you see the technical DCB related complications, the numbers are really very small, 3.3%, and bailout stenting rate also very less, 3.1%. And if you look at MACE events at 2 years for the de novo lesions, if I'm allowed a minute. Okay. So ischemia-driven TLR rate is just 2.9%. So these are the factors which say that paclitaxel-coated balloon stands a chance in this kind of anatomy. Imaging, it goes without saying, is essential in this kind of patients. It's a class 1A indication. What we want to look at is whether it is a link-free carina or not, and whether left main stent previously deployed has got malapposition or not. So imaging is very crucial apart from selecting appropriate balloon size. And therefore, this is a patient which I treated in year 2019 with the help of stents. But given a chance, if I have this anatomy to treat today, given the evidences with registry data and the paclitaxel-coated balloon technology, I would consider that as a valid option as of today. Thank you.
Very well. Good morning, everyone. Now I have a privilege to invite next speaker, Dr. Asit Joshi, sir, who will give argument in favor of drug-eluting stent. The lesion is being atherosclerotic in nature.
Thanks, Kamal. LCX osteal stenosis itself is a controversial thing, and probably there are some trials of directional atherectomy with DCB in isolated LCX stenosis. However, our case, which is a provisional stenting, crossover stenting, LMCA to LAD, now has presented with a new lesion. Novo ostial LCX lesion, 80% lesion. So now there are many unanswered questions. One thing is time frame from last procedure. When did this de novo lesion occur? Whether it was immediately after the procedure, the process had started or not. Whether it is a new lesion developing right now. Whether there is any instant restenosis in the LMCA to LAD stent. Now previous procedure needs to be evaluated, whether there was an imaging guidance, what were the images at that time, how was the stent expansion, what was the malapposition at that time, what was the circ ostia disease at that time, whether there was any less than 50% disease at that time which has progressed or not, whether there was any circ ostial luminal loss during that procedure or not, whether kissing balloon was done at that time, and whether there was balloon injury at that time or not. Again, we would review the angio or imaging done during this procedure. What is the ostial morphology? Whether it is lots of the circ ostium, even without a stent, would be quite fibrocalcific. And ostial circ distal LMCA always has more fibrocalcific lesions rather than other ones. Now LMCA, LAD angle and LAD circ angle, distal proximal angle and distal angle also would modify our treatment. So this is trial, change in left main bifurcation geometry after a single stent crossover technique. This is for initial procedure. So the conclusion was that lumen loss at LCX ostium frequently occurred after crossover stenting from distal LM to LAD. The main mechanism was carina shift that was associated with a narrow angle between LAD LCX. So if there is a narrow angle less than 70%, there is always carina shift, and 10 to 20% of LCX ostium luminal loss is present. So if that occurred during the first time and that has progressed over that, so crossover stenting is not an option. Distal carina angle, these are the same trials which shows that the distal carina angle changes from 70 to 86% and the luminal loss occurs more than 20%. Second thing, the eccentric index of EEM changes with stenting, and there is eccentric angle, that is alpha and beta upon alpha changes during this. So the circ ostium is, after crossover stenting, is quite oblong, not a routine round which would be there. So post procedure, the percentage change in MLA within the LCX ostium and percentage change in LCX carina were about 20% and 30%, negative 30% respectively. And the percentage change in MLA with LCX ostium significantly correlated with changes in EEM eccentricity index. So now, whether to consider this lesion, circ ostium, as 001 or 111 and how to treat them. Of course, we'll look at syntax score, syntax 2 score and decide whether surgeries would be given. But most often we consider right here that probably this is a case for intervention. So now the main thing will be that would you consider this as a 001 or 111? You will treat left main also or just circ ostium. So what is definition criteria for complex bifurcation requiring two stage? And the major criteria involves circumflex for LMCA. Side branch lesion more than 10 millimeter and side branch diameter stenosis more than 70% is a major criteria. Moderate to severe calcification, multiple lesions, bifurcation, lesion angle less than 45 or more than 70. So if this is present, probably a two-stent strategy is better. 3 years outcomes with two stents. Now this definition 2 trial was done up to 1 year, but when it was followed up for 3 years, the increase in difference between 2 stents and 1 stent persisted up to 3 years. Similar results, this is definition criteria for complex lesions. Similar trial, DK Cross 5, that was the landmark trial, and this was 1 year results were better with 2 stents with DK Cross in complex cases. Now this was seen that at 1 year the difference which was present increased over a period of time of 3 years, and the editorial said that complex stenting for complex lesions, DK Cross 5 calling for novel treatment strategies for bifurcation lesions, and DK Cross technique as standard for complex unprotected left main bifurcation. So now probably we will consider this as 111, and we'll consider this lesion as an unfinished business from the first procedure. There are 2 ways to approach this. One is a provisional stenting. Consider this 001, then we would do provisional stenting from LMCA to LCX crossover and stent the portion and then dilate the LAD as a side branch. But I would rather go as this as 111, giving a large LAD 4.5 vessel. I would go as 111, treat that as a LAD which has already been stented and the side branch being compromised. So there I would go for internal or reverse cross. And there are studies that internal cross or reverse cross is as good as DK cross technique in long-term outcomes. So first thing would be imaging. This case always requires imaging either with OCT or IVUS, whatever is available. IVUS probably preferable. Via both branches. During imaging, we have to see whether there are the LCX ostium is jailed or not. Previous intervention, whether there was a kissing balloon done or not, and whether there are any struts overlying the circumflex. Via both branches, circumflex probably with imaging guidance from distal strut. Dilate LCX appropriately. Plaque modification, lesion preparation has to be done adequately. Deliver LAD balloon, deploy LCX stent, remove balloon, cross LCX stent. Then rewire the LCX stent, preferably from proximal strut or non-distal strut at least. And this has to be confirmed with, again, image guiding so that the distortion of LCX stent does not occur. Then kissing balloon inflation has to be done and a port and a final imaging has to be done. This would be my approach for this case. DEB, pros and cons. There are lots of cons. DEB, there are trials with, de novo lesion. This is a de novo lesion at ostium, and probably it would be quite fibrocalcific, especially after the balloon injury if has occurred during the first procedure. Second thing, stent struts overlying. So to open this stent struts also we need to do, and proliferation in previous stent also might affect this. Eccentricity index also we have to see. Evidence for DEB, the gap in, this is again also from the editorial reply to editorial of DK Cross 5. The gap in evidence can be summarized as follows. The guidelines of ESC, EBC does not mention DEB in bifurcation. The document only considers DEB in wrist stenosis. Anecdotal reports of DCA plus DEB. Many Japanese studies have shown that using adequate DCB to the circ ostium and then doing DEB and not using stent has good result. However, this is not applicable to this case because of doing a DCB in a stented portion probably would be a large device would be required, and already a stented thing is there, and again it is not a randomized trial. Just 1 minute. Pros for DB, if we want to do a DB, we can take heart from this, from EBC recommendations 12th and 13th concession statement. It is Bifurcations try to keep it simple, limit use of stent. This should cheer up to test in further trials the results of DEB versus double kissing strategy. Till then, it's a long road. We need trials. Thank you.
Now I would like to invite Dr. Mapekar Masadi Madam for sirolimus drug-eluting balloon with nanotechnology is the best strategy for branch vessel revascularization.
Good morning, everybody. My topic again is extremely specific. It's a sirolimus drug-eluting balloon with nanotechnology, if it is the best strategy for a particular case. My job has actually been made very easy by the previous two speakers, and I'm not going to discuss. I have had to actually change a few of my slides. So if I do sound staccato, I'm sorry about that, but I did not want to repeat everything that my previous speakers have said. So again, like I said, I'm not going to discuss the case. So why do we like a DCB? DCB, or a drug-coated balloon, is very favorable in PCI because first of all, there are no metal layers. There is reduced need for prolonged dual antiplatelet therapy. So especially if this particular patient, we are not aware whether he was a high bleeding risk or not, but definitely high bleeding risk patients, DCB is preferred. You can repeat the procedures innumerable number of times again because there are no metal layers and there is reduced vascular inflammatory response. So what are the recommendations? The recommendations, particularly in this particular case, use of DCB in bifurcation lesion is definitely recommended, and even by the Chinese experts and the German experts, DCB in bifurcation lesion is definitely recommended. Excuse me. So this again is the mechanism of action of a drug-coated balloon. The drug is coated on the balloon, and while it comes in contact with the vessel intima and media, the drug gets delivered into the system. So why do you need a DCB in a bifurcation lesion? What is the treatment? Sorry about that. Again, in this particular patient, the vessel is large, a DCB is definitely available, and we have to see whether there is suboptimal results during predilation, and there is a possibility of recurrence, which is definitely there in this particular patient. So again, a DCB would be a preferred therapy. I've earlier said about this particular thing, so I'm not going to repeat it. So technically, we would like to do an imaging in this particular patient, a good IVUS measurement, vessel sizing, pre-dilatation with an appropriately sized balloon, modify the plaque adequately, use cutting balloon if necessary, use a calcium modification technique if necessary, then you have to use DCB. DCB, again here I would like to say that dissection is not a limiting factor. If it is not a flow limiting dissection, then DCB is definitely a preferred option. Again, after doing DCB, a final imaging is of utmost importance. I'm not going, this was all a repetition of the previous people, but again, these are the available DCBs. There are paclitaxel coated balloons and the sirolimus coated balloon. I've been specifically asked to talk about nanolute technology. So here I'm going to say why sirolimus and why nanolute technology. Both the drug sirolimus and paclitaxel, one of them is a cytostatic and one is a cytotoxic drugs. Sirolimus has a slower absorption and tissue retention is a little shorter, while paclitaxel is a cytotoxic drug and has a fast absorption, retention also is long. Both paclitaxel and sirolimus show inhibition of the cell cycle but have very different modes of action. Sirolimus retains the degradation of cyclin-dependent kinase inhibitor that plays a crucial role in vasomotor regulation and represents the initial phase of cell cycle. Paclitaxel also arrests the cell stage in which they're supposed to divide, and pro-apoptotic mechanisms are likely to occur, leading to apoptic cell death. Now, what are the advantages of a nanolute technology? It facilitates a better adhesion of sirolimus on the balloon surface. It's an effective drug transfer to the deepest layer of the vessel. It's a circumferential coating. I guess all balloons do have circumferential coating, and it's better in tissue availability of the sirolimus drug. There's better adhesion to the balloon surface. Drug delivery is possible to the innermost layer for better bioavailability, and it's an efficient particle diffusion. Here again, that's a repetition of what I've said earlier. Sirolimus and paclitaxel are almost similar in action, and they are both effective in preventing restenosis, but sirolimus may have a safer profile and late stent thrombosis. Again, choice depends on the patient, on the renal function, on diabetes, etc. A lot of other factors are present. Here the key differences are paclitaxel is absorbed a little faster than sirolimus, and it is retained in the tissue a little longer. So coming to Magic Touch, our center has had a study which had 450 patients. It's a multi-center trial. A lot of centers are taking place. Here the primary endpoint was MACE as composite of cardiac death, target vessel revascularization, target lesion, revascularization at 6 months, procedural success, which was defined as technical and angiographic success, and the secondary endpoint was MACE at 1 year. And here you can see that Magic Touch demonstrated a promising rate of MACE of up to 3 years. Here again, implanting or how to use a DCB. Optimal lesion preparation, I have already said earlier, has to be done properly. And here I'm going to just show you a case of almost a similar situation that we've had a case over here. So here this gentleman had post bypass and he was extremely calcific, heavily calcific. We had planned a TK crush, but because of whatever reason we had a geographical miss, and then we used a drug-coated balloon, sirolimus coated balloon, to treat his osteal lesion. Again, most of the studies that I'm going to quote here have been previously presented by my colleagues. So here what I'm going to say is, this is the landscape of the limbus coated DCBs, and this is where we stand. And this particular patient, if the lesion preparation is good and a good imaging facility, I would definitely go for a drug-coated balloon. Thank you.
So in Leffman intervention, any osteal lesion, now osteal stenting is not preferable because there are high chances of geographical miss and or protrusion of stent in the Leffman. So we are preferring crossover stenting. So I would like to ask Hasid sir, is there any role of final kissing in crossover stenting or a role of a drug-coated balloon in final kissing?
Yeah. See, crossover stenting, there is controversy whether final kissing is required or not. So there are FFR guided studies that if FFR of circ is normal, you don't do anything to circ. Don't give the balloon injury. However, the opposite view is that you should expand the stent struts and at least open it so that there are no stents overhanging in circumflex. Most often, if there is no lesion in circumflex, ostium, when you do imaging prior to the crossover stent, if the circumflex is normal, and post stent if FFR is normal, then probably you don't need to touch the circumflex in the initial.
In like in our case, patient is having restenosis as osteal LCX. So from your talk, if angle is more than less than 70 or lesion is more than 10 millimeter or fibrocalcific lesion, so reverse crush is necessary. Or otherwise, if angle is more than 70 and atherosclerotic lesion, so drug-coated balloon is...
No, if angle is more than 70, also I would still go with stent. But then rather than doing a reverse crush, I would go with a T or T-tap.
In which case you will use a drug-coated balloon?
Drug-coated balloon till evidence comes. See, it is an easy option. If your imaging guidance shows that it is just a simple lesion, 80% lesion, there are cases in which thrombus has occurred at 2 years in the circ. The thrombus is at the distal LMCA and LCX ostium. So it is a simple fibrotic lesion. If you dilate it and you get a very good result without any dissection, and it is a short lesion, just ostial, then probably a drug-eluting balloon would be an attractive option.
I would like to ask Chirag bhai, are you believing stentless ostium in isolated osteal LAD or osteal LCX lesion?
It's a difficult anatomy to live without stent at LAD ostium or a circumflex ostium. Nonetheless, we have to still understand that circumflex ostium is the Achilles heel. I mean, very high chances of restenosis, and the lesions are most often fibrotic. And therefore, it is intuitive. Whenever one sees left main, one would consider stent to both, left main as well as LAD. I mean, LAD as well as circumflex. But on the other hand, we have to still consider that whether you have imaging available or not, because chance of MACE, when you treat left main with 2 stents, in appropriately selected cases, if you do with decay crush, fine. But if you have to convert that decay crush to inverse or reverse crush, outcomes are not as good. So prospectively, you have to choose the patient right, who should be treated with 2 stent and what should be the strategy. Then only you can give a good long-term outcomes. If you have a provisional arm wrongly selected, circ gets compromised, and if you go for a reverse crush strategy, outcomes are not as good. And therefore, if you happen to have this kind of scenario, then the middle way should be that you again perform imaging, do a cutting balloon at the circumflex ostium, and treat with drug-coated balloon. If you don't have dissection, leave it there. If you have flow-limiting dissection, go ahead with stenting. Leaving behind that, if you treat with a drug-coated balloon and prepare the lesion with a scoring balloon or a cutting balloon, which would ensure that there is good luminal gain, it would definitely be much better option than 2-stent strategy at left main bifurcation, provided the lesion is short, focal, restricted into maybe 5 or 7 millimeters of circumflex ostium. There is some sense in avoiding a lot of metal at the circumflex ostium, especially length of neocarina. Whatever neocarina you form, higher the length of neocarina you are forming, there are higher chances of MACE rate, depending on the centrality of that neocarina. And therefore, imaging will tell you a lot of, it will give you a lot of insights into predicting what is going to happen to that patient. So I believe there is some role, definitely a role of treating in focal lesions with a cutting balloon and then use a drug-coated balloon and leave it there, adhere to the single stent strategy. That may be a good outcome.
One correction I would like to say.
See, lesion modification is extremely important. If it is a fibrotic lesion, then cutting balloon definitely helps. And for using DCBs, we have actually, our center does have a very large experience with that, and we have been discussing with a lot of other people in the world who are using it. A dissection definitely is preferable for a DCB if it is not a flow limiting dissection. Linear dissections are always preferable. If there's a slight dissection and if you're doing a DCB, it will definitely give a longer result. Like my previous speakers have said, circumflex ostium, again putting 2 stents and putting multiple layers of metal, it's at least better to treat with the DCB in this particular situation.
There was one trial of provisional stent which had to be converted to internal crush, and the 3-year results with reverse crush versus decay crush were equivalent. So when you are doing a bailed out, say provisional, and you do a bailout reverse, then you don't have the decay crush option. Then internal crush is the best option.
I guess it's a must in all. Most of us don't have imaging. Imaging in these situations is a must.
Yeah, I think imaging would be mandatory if you're doing. But I think EBC also mentions that keeping it simple, if you can get away with one, never go for another one. Ostiums cut and do a dab. In a randomized control fashion, we don't have a trial. DCB versus a stent in an ostial, we don't have a trial. But coming to a true bifurcation lesion where you have to do 1-1-1 and you have to do stent strategy, except DK Crush 5, I think the one stent strategy always plays big role. Most of the endpoints have been 1 or 2 years, no data sets for 5 or 7 or 10 years. Event rates lesser, but only for 1, 2, and now the DK Crush 3 has come. 5 got 3-year follow-up. But 5 years, 7 years, we don't know.
3-year follow-up, it still is diverging more and more.
Yeah.
Towards in favoring 2 stents, and in definition 2 also 3 years results have come.
Are better.
So in complex lesions where both distal circumflex where both are involved, and circ ostium is the key. If it is more than 10 millimeter and more than 70%,
Yeah.
then always 2 stent strategy better.
But that's only DK Crush 5.
Crush 5 and definition
Yeah,
2.
and definition 2. But again,
EBC
still EBC still says one stent if you can get away. Don't go for a second one. Of course, that in criteria, that is the quiz. Can we have the quiz? So when do you do? All those who are on quiz. All of the following are preferred criteria for Cullet over DK Crush as per EBC guideline. Cullet versus DK Crush. So 2 different techniques. Angle less than 70, branch more than 2.5, more complex and calcified, and large main branch diameter. Large main, complex, side branch, or angle less than. Angle, if it is more, not less. If angle is more, that's when you prefer Cullet over DK Crush. Less angle, DK Crush is preferred. So that was the right answer for this quiz. If there are no other comments, we can close the session. This time Charmi, Parshu, Priyanshu and Vanvi got it. But quickest was quickest? Pranshu Thakur. Here's was Pranshu Thakur. Pranshu, if you can come. This is a total leaderboard of the previous 2 quiz. So Pranshu Thakur, if you can come. Yes, Pranshu. Thank you very much. We can have a photograph with the speakers. Thank you very much, speakers, chairpersons and moderators.